We are excited to launch this with you all. Today you have both myself and Dr. Miller, and this is using food as medicine in the exam room, training number 1 of 4. We are so appreciative to Dr. R and the rest of the team at Bach for creating time and space to invest in frontline staff, prescribers without MAs to get trained up on this, because many of us didn't get this type of training. So there are 4 sessions, 2 hours each. I'm going to do a quick intro just for Dr. Miller. I feel so pleased to be able to work with Dr. Miller here. Dr. Miller and I know each other from doing our fellowship in integrative medicine through Andrew Weil Center for Integrative Medicine. And she's amazing, a superstar in the field, certainly a clinical professor at UCSF, but also on the leadership faculty at Lifelong, their family medicine residency, and as an author. You've probably seen her books. So super excited to have her as my partner in this work together. Dr. Miller, do you want to say anything in particular?
No, I'm just really excited to be here and co-teach with Stephen, and nice to meet you all. I think we probably have a lot, all of us, to learn from each other here today. So very excited to be here and work with you for the 4 sessions.
Fantastic. And just a little about me, I'm a family medicine doc as well. Do a lot of integrative medicine, blending in food, acupuncture, manual medicine, and functioning as a chief medical officer with the rest of the team. Karen is here as well. Karen, you want to say hi and just share what you'll be doing?
Hi, welcome, Karen Ben-Moshe. I am healthcare program manager with All In, and I help with coordination. And if you have any issues during the course of the next 2 hours, feel free to put it in the chat and I'll be checking or chat me directly.
All right, fantastic. So we're going to jump in. The standard stuff, because this is CME, you can get CME and CEUs. There will be a survey at the end. You'll have to complete that in order to get the CME and CEUs, but we have no financial disclosures. And just to level set, this is a tough time right after clinic. You've been busy. You have 2 hours now. You're hungry, potentially. So starve your distractions, feed your focus. The more you are able to put in, the more you're going to get out. We recognize this is a 2-hour training. If you need to use a restroom, take a stretch break, just do it as needed. We will do check-ins. We're going to rely on you all to kind of guide us on the pace. Every clinic we've worked with is different. Some really get super interactive verbally, some type of way, some are quiet, and it depends on how much you guys want to go. We have a lot of content to cover, and it'll just depend on how much you guys want to talk about stuff. So just to level set as well, I know that we have been working with you all. You have seen us at the kickoff. There are different types of trainings. And so just to make it clear, so folks are clear about the progression, this set, what we're doing today is kind of our clinical nutrition training set. It's for all prescribers. And we say prescribers, as you know from the kickoff, as more than just the medical providers, right? We have nutritionists who are prescribers, coordinators who are prescribers, behaviorists. And there's a lot of people who can help our patients from a more decentralized approach to take care of our patients and offer them some of the interventions. 4 2-hour sessions spread out over time, January onwards till the end of March. This is a different set than what's going to happen in about 2 weeks. We're going to have workflow trainings. That'll be a 1-hour set. That's it, 1 hour. How do you do this in Epic? Clinic ops, kind of all the flows of the clinic and who's doing what. The MAs are getting trained. The prescribers here will be trained separately because their workflows are a little different. And once that happens, essentially we're kicking off with referrals. So the Recipe for Health program begins. You have the ability then to write referrals to the food pharmacy, behavioral pharmacy, once we finish training on January 19th. So we're 2 weeks away. So we're really excited. This clinical nutrition set is by intention spread over time, because we recognize this is a new skill set. And when we build the operations in, the ability to do this, you'll have questions. And so we're excited to journey and partner with you on that. Thank you for completing the surveys. I'm going to go through the kind of standard objectives, kind of a CME approach. Hopefully the language is not kind of too academic and it's kind of very straightforward. Overall, for all of the sessions, we're trying to increase your skillful use of, quote, food as medicine. I always like to say to treat, prevent, and reverse chronic disease, because we see that when you've been in practice long enough, even in early in practice, you'll see patients make dramatic changes using food as an approach and the other life habits around that. And this is really to skillfully, or to provide you skillful use in that one-on-one clinical encounter. When you're in your 15-minute visit, when you're on your phone kind of doing coordinating work, when you're at an RD visit or a registered dietitian visit or whatnot. And then to know that we have structures in place to support you with the food pharmacy referrals and the behavioral pharmacy referrals. Specifically, we put these objectives out. We're going to have some variations today. Dr. Miller and I have been adjusting the curriculum based on feedback from other clinics. And so we're going to touch on aspects of this, but not all, probably in the same depth that you might want. And I'll share the next slide. So understanding and applying a spectrum of nutrition interventions that are likely to produce health benefits. We recognize there's different levels of evidence around the different types of nutrition interventions. And our hope is to give you and to share with you and to learn from you the various approaches you can take. And then the dance is to work with your patients using an MI perspective, motivational interviewing perspective that's patient-centered. Where do they want to start? The second objective will be really diving into final common pathways or just common pathways around what links a lot of chronic disease. And that's really describing how insulin resistance is a final common pathway that can link the many things that we see in clinical medicine. Number three is to use a metabolic health framework. So it's not just about disease, but how do we think metabolically about our patients, cardiometabolically? So as a framework to identify early clues to chronic disease, so you can start working upstream in your clinical encounter. We often talk about the work that we're doing is upstream at the clinic level. We're trying to reach into the population. We in healthcare have an opportunity to stand up, to wake up as a sleeping giant, if you will, that consumes a lot of funding all across the nation, to start thinking more upstream in our clinical encounters. And we'll talk about how that actually looks. And then this is really a core piece. This is this kind of three pragmatic approaches: the when to eat, the what to eat, and how to eat, which all have impact on insulin resistance. And we're going to talk more about that, especially the what to eat. We'll cover briefly, not as much as you would want. So when you do your CME review, you will probably not be able to answer, say that we did a lot of this, because the satiety and hunger we're going to bring in probably in the next session. But I want to just name and mark this as an important piece, because that's when we're talking about food with our patients that comes up. And then finally, a concept that we'll be weaving throughout, this concept of just removing, replacing, and combining. We're going to talk a lot about removing today, but also replacing, and then build on this. Again, we're giving you chunks, and we're going to come back to this information over time. You are the 5th health center in Alameda County to be joining the Recipe for Health partnership. And so we're really excited to launch with you all. Questions, clarifying questions, any things that this is bringing up for you all, feel free to chat away. I can't see you as well, so I will rely on chat. All right. I do want to just kind of say, if you are tuning in now and then you kind of are tired, you're thinking about a patient and you come back, at the end of the day, like, what are you going to get from this training? We're going to really focus today's training on 2 practical steps. Focus on the what to eat. We'll get into the when to eat next time, and the how to eat is partially in and out here. But the what to eat is where we're going to spend a lot of energy. And it seems fairly straightforward. Remove sugary drinks, replace with water, teas, coffees, replace with all other options. Number 2, remove refined carbs, or we should say processed carbs. Replace with veggies, fruits, legumes, fiber. I would say, though, that what we're trying to do in this training is to not just give you a laundry list of things like we do with sleep. When we say sleep hygiene, you can do these 10 things, and then patients are like, yeah, great. I don't understand why. I, as a clinician, don't kind of see the connections. We are trying to provide and fill in the background why behind these recommendations. But then to not get lost too much in all of the science, to then be able to say, you know what, at the end of the day, when I'm done listening to Stephen and Daphne and the team, we've all talked, what am I going to do at 1 o'clock when I see that first patient? Oh yes, I can, let me just start in that 15-minute visit on the sugary drinks, or maybe it's the refined carbs or the processed carbs. Questions on this? And you guys are new to me, so I don't know if you guys are a talkative team or not, but I am so open to you all jumping in with questions along the way or typing in questions. All right, going to do some level setting in terms of the function, the role of diet. An unhealthy diet is actually, from a risk factor perspective, is the leading cause of mortality based on some 25 years of kind of epidemiologic work. Uh-oh, my computer is slowing down. There we go. So if we look at a bunch of risk factors, dietary risks, tobacco, blood pressure, body mass index, glucose, cholesterol, etc., you'll see that dietary risks actually top them all. And that if we looked at it this way from a risk factor analysis, that is 500,000 people dying per year. So we're at 800,000 with COVID over 2 years. There's 500,000 from the dietary piece. 26 years of data, U.S. Burden of Disease collaborators. I'm going to turn this over to Dr. Miller, to Daphne, to share more on this piece.
So today we're going to be focusing specifically on nutrition and diet, but also to understand that we're thinking about larger lifestyle interventions as we move through this too. So getting healthy is not just what you eat, it's how you move your body. It's how you relax or manage stress. And we also want to acknowledge that there are many other things that are beyond our patient's control as well, in terms of the environment and social issues. Recently, we've talked a lot about the social determinants of health and how all of these affect our health. But today, focusing specifically on food, I think it's really important to acknowledge that there are many paths to healthy eating, and that we're not here necessarily to prescribe one diet. And if you look on this slide, these are foods from all over the world that are very much could be considered healthy. I don't know if I can't see all of you there, but maybe you can guess which one of these is from Northern Europe. There's a Scandinavian diet versus which one is from South Africa, which one is from Crete, which one is actually from Northern Mexico, which one is from Southern Japan, which one is from the Philippines. All very different flavors and even different ingredients, but could all be considered healthy diets. And we're hopefully going to address, a lot of these potential food combinations in the next four sessions. Next slide, Stephen. But one thing that we really also are going to layer on this, which is a relatively new concept, is the idea of a planetary diet. So that when we're thinking of eating for health, we're not just thinking about the health of our own bodies, we're actually thinking of the health of our environment and the planet as well. And this is something that is being discussed more and more. How can we select foods that are grown ecologically, that are using seeds that are resilient, that are not using too much water, that are protecting the environment and our bodies in terms of uses of herbicides and pesticides, that are minimizing the use of fertilizers and other inputs. And so as we make recommendations and as we consider traditional diets from around the world and also our patient preferences, we are going to frame this within a planetary diet framework as well. And finally, looking at the very local level, if you can show the next slide, Stephen, the food that you are going to be prescribing very much meets that idea of a planetary diet, and that it is part of the local economy here in Alameda County. It's grown by folks here in Alameda County using sustainable methods, and is actually supporting local farmers, local distribution areas, giving new jobs, is reducing food waste, reducing food miles, and is all healthful food that we would be recommending within, you know, the nutrition principles that we're going to talk about. So the food that you are going to be using in your food prescriptions is actually a part of this planetary diet plan.
So thank you, Daphne. And I want to address this question because it comes up often. Stephen, we are so busy in clinic dealing with COVID, my patient with 5 to 10 problem list issues with 15 meds, and you want us to talk about food and life habits, if you will, and is that even possible in 15 minutes? Is anyone actually out there doing this? I want to share the case, and I want to answer the question, yes, it is doable. In my own practice, I've done it. I worked at Asian Health Services, one of your sister clinics, right out of residency, and then worked at Hayward Wellness in FQHCs. That's been my whole life. So personally, I know Daphne is at Lifelong doing it. I want to cite an example of somebody from the UK. The UK, he's kind of become one of their physician GPs of the year, if you will. And he's a primary care. He has his own practice. They have shorter visits, 10-minute visits. This is his name. His name is Dr. Unwin. I'll give you a YouTube link someday. You know, offline, you can come and check him out. He just did a case series of his own patients, of 128 patients. He just has a panel of like 9,000 patients with his practice. But he did a panel of 128 patients. This is over 15 months. This is not some RCT study, right? This is observational, real world, what's happening to my patients. He often led with this question, and I love it because I use it as well when I'm going over data in labs with my patients. And I say, hey, you know what? I'm worried a little that you may need to be placed on lifelong meds for this condition. Would you be open to an alternative? He uses it as an opener. I love it because most people say, I'm absolutely open to an alternative. I think he's often said that. I don't think he's ever gotten someone that says, no, I only want to be on meds as an opener. His approach has been 10 to 15 minute primary care visits. He does have a group, kind of like we're going to create that behavioral pharmacy group for you all, not as robust as ours. He focuses a lot on glycemic index. We're not necessarily going to be talking about that today. In his practice in doing these short visits, he's just started integrating the food piece and turned his whole practice around. He was kind of nearing retirement. He's like, oh, I'm done. I'm burnt out. Patient results, he was showing over 15 months, his patients were averaging an 8.6 kilogram loss in weight, a drop in hemoglobin A1C of 2.1, and then ALT, they're using GGTs, but a change in liver inflammation. What does this mean in terms of, and this is a video you could watch if I'm following up with him, what does this mean in terms of treatment and reversal and of chronic conditions? His pre-diabetics, 93% of them attain normal hemoglobin A1C. Often we think it's a progressive march to badness. It can be shifted, especially pre-diabetics. And then even his type 2 diabetics, 46% of them were in drug-free remission. So it is possible. Reversing prediabetes and diabetes is possible in busy primary care practices. Just to put it out there. I'm going to turn this now to Daphne to talk more about some of the data.
So don't let your eyes get too blurry with this slide. It really is meant as sort of a meta slide. But the question, just what Stephen just said and gave you one particular example of a physician in the UK. But just to understand that this question of can you prevent progression to type 2 diabetes or even improve outcomes when someone has type 2 diabetes or move them back along that progression has been studied a lot at this point. I mean, I think you're all familiar with the original diabetes prevention program trial, which indeed lifestyle interventions can work just as well, if not better, than starting medications. But that was a big clinical trial with lots of NIH money and so on. And what's actually quite hopeful is since then, a lot of smaller trials that are much more real life have been done in lots of different settings, including for folks working for the city and county of San Francisco and around the country. And those too have shown similar benefits. They've all looked at slightly different interventions when it comes to diet and lifestyle. They've all had even different outcomes in terms of hemoglobin A1C versus weight versus a lot of other factors. But if you look on this, the solid horizontal line, everything that's left of that horizontal line favors the prevention program, and everything to the right favors usual care, which is what we typically do with metformin and other things. And as you can see, pretty much every study favors the lifestyle intervention program in terms of its outcome. So there's still a lot of gray area here in terms of what are the best interventions, even when it comes to nutrition, what exactly we should be doing. But we feel like there's a preponderance of evidence in this area, and certainly enough of the sort of pebbles making the mountain of evidence that nutrition interventions themselves make a difference, that we really have to get started on this. So this is a little bit of data just to support the work we're doing.
And just to punctuate it, if you total up all of these studies, if you're into risk ratios and relative risk reduction, you have 0.66. So essentially it's a 34% reduction. So it's fairly impressive, right? So yeah, go for this case, Daphne.
So we really thought that we would have some patients bring us through the next 4 sessions, because after all, that's why we're all here, is to work with our clients or our patients and make a difference. And we wanted to make this very practical. And we know that there's a wealth of knowledge in the room. This is Mrs. C, who is someone that I saw very recently in my practice. She's 48. And she came in for her first visit, and her agenda for her visit was, she said to me, I want you to help me with my knee pain and my upper belly discomfort. I feel really bloated, especially after I eat. Now, I'm sure this is not an unusual request for you guys to hear this. She also commented, she said, also, I'm really physically active. So why have I gained so much weight since I moved here from Mexico in 2015? She was originally from the Veracruz area of Mexico and had moved up here to live with her family. So she lives with her children and her grandchildren. And she also said she's bringing in the whole family to be my patients. So this is Mrs. C. Next slide. And these are her, before I even saw her, these were her vital signs. And I should add, waist circumference is not something that is typically checked in our clinic, nor would I guess is it something that's typically checked in your clinic. This was part of our healthy eating group, and we do a waist circumference baseline for that, and we'll get into that in a little bit. But her waist circumference was 40 inches. Her BMI was 28, and her blood pressure was 148/92. Next. And we did some labs that came back pretty quickly. I'm just gonna, share those with you for a second, but then we'll just put those on hold. Triglycerides of 200, HDL of 32, hemoglobin A1C of 6, and an ALT of 35. Next. So I think what would be really helpful here, Stephen, is maybe if we get rid of the slide as soon as I ask this question and have us chat for a minute so that we're actually looking at each other and not the slide. Would that be possible?
All right, let me figure that out. Yes.
Mrs. C asked, can you tell me, oh, this is actually, you move this to visit one. Okay, there's a little bit. So you actually, let's pretend that you're able to do those labs right away in the first visit, which I actually can't do in my clinic, but I know a lot of you do get lab results pretty quickly. So you give those lab results to Mrs. C, and she says, can you tell me what my lab results mean? What would you tell her?
Daphne, do you want me to keep this up? Because sometimes people might want to look at the numbers and then talk about it.
Sure, but really, if there's a way to do that and reverse it so we're all in the room together rather than with a slide?
I'm not sure. I can stop it if you guys have a good sense of the numbers and then the blood pressure, and I'll just kind of go off. Let's see, does that work?
Yeah, we can put it in the chat. There we go. Wonderful. And if you want to turn your we have very few people who are on camera here. It would be lovely if some other folks could come on and join the conversation. Wonderful. Thank you, Allison. Thank you, Harsha. Yes, I pronounce it. Wonderful. Sangita, Miss Espinosa, A. Espinosa. Wonderful. Welcome. So, what would you feel free to either put it in the chat? Do you guys feel more comfortable doing the chat or unmuting? Given how few of you are actually on screen, maybe we should start with the chat. What would you say to Mrs. C based on those labs? Someone wrote metabolic, Mila said, you have metabolic syndrome. That's what you would tell her. Other things. She says, what are those labs showing me? In real life, what would you say to Mrs. C? Any other ideas? Okay,
Dr.
well,
Miller,
everybody's
I'd be more than happy to share what I would say to my patient if she had those labs.
Yes, what would you say?
Well, I would say, we're going to need to work on your sugars because you're in the pre-diabetes. So that means you're at risk for diabetes. So that's something we can work on right now. And your protective cholesterol, it needs a little work too, because you have this number, they call it HDL. That's your protective cholesterol. It looks like it needs a little work, and your triglycerides are higher than I'd like it to be. So these are all things that we can start working on, I think.
Wonderful. So pre-diabetes, I'm a little concerned about your cholesterol. There's work that we can do together. Those all sound like great answers. Anybody else?
I would focus on the blood pressure also, and which Mila already said metabolic syndrome, which is great, and it's a very common labs that we see in our population here. So you need to work on your blood pressure, which is also high, weight, triglycerides, HDL, which is low, and also the pre-diabetes.
Right. Okay. So I'm Mrs. C, and I am sweating a little bit here. But yes, I agree. Someone else wrote abdominal obesity. She needs work on weight management. Okay, so it seems like there's lots of clinical opinions here, which is just terrific. So let's go back to the slides for a second.
Okay, about to do that.
Okay, and
can you guys see the slides?
Yes.
Okay.
Okay, and then back to my question, because I think
Great.
that there's a two-part to it. Okay, can you click on that? Because I should have done this. Okay. So let me actually go back to our SAGE providers there and say, how might you connect her objective findings, like her objective findings, to the things that actually brought her into the clinic, like her knee pain or her bloating? Because if we can go back to the full screen again, Stephen. Are
you guys not seeing the full screen?
No, sorry, the room. I guess I'll call it the classroom.
Okay, got it. Okay,
let's call it the classroom for. Yeah, so let's go back to our providers. So, we all, my guess is that there's a lot of years of clinical wisdom in the room, and we all know that we are not going to have a happy patient unless we actually connect what's going on to what brought them there. So she came in for knee pain and bloating. How are you going to connect what you've seen to those? And potentially in a way that might be actionable.
We can look at the BMI. I mean, her BMI was higher, 28, and the increased BMI can cause worsening of the knee pain or osteoarthritis that she might have.
So wonderful. So a change in recent weight. There's actually interesting evidence that high BMI in and of itself is probably not correlated with that at all, but a sudden change in BMI so that the physical structure is not used to carrying that weight could be, for sure. Okay, so more of a plane taking off than a plane that's just flying high all the time, right? So what else? Other ways you might connect it?
Well,
the bloating. Any thoughts?
The bloating, I would probably use that as a segue to ask, do you notice any foods that cause that? Like if you eat certain things, you find you have more bloating than others? Because we probably should look in what those types of foods are, because they might be also connected with, your cholesterol, your sugar. If, they fall into those families, inflammation, there's certain foods that can cause that. So.
Wonderful. So, what foods is she eating? And then this idea of inflammation, right? That we're really beginning to understand as an outcome from this that might be affecting the bloating, but it could be affecting the knees too, right? Where, inflammation is something that we can feel in all different parts of our body. So these are terrific answers. And once again, I still see there's a lot of folks off camera. Some of you are answering in the chat, which is great, but please, continue to join us in this conversation, because then we'll get to hear your expertise as well. So let's get back to the slides.
Right.
So Stephen's gonna give us a little bit of the why behind all of these ideas that we've been putting out.
Yeah, and this is where we know that everyone learns differently, right? And so I kind of am that kind of internal medicine mechanism. I need to know the why before I kind of jump and do this stuff. And so we're going to bring you into some of the why. So a common pathway to metabolic syndrome, as I think Myla mentioned in the chat, is, and chronic conditions, right, is this concept of insulin resistance. When you are, and I'm going to go into the why behind that, but we have seen this pattern. My professor in med school at Stanford, Dr. Reven, was the person who discovered syndrome X, which became insulin resistance syndrome, which is now metabolic syndrome. The definitions I'm not worried about for you all to remember, because even that definition around metabolic syndrome is being examined and thought through. The idea is to say, what is connecting all these diverse things? Because normally we think, oh, diabetes is one thing, weight is one thing, maybe there's a connection there. Blood pressure, yeah, but how does insulin go to connect with blood pressure? What about lipids? How is that connected, right? We see these and we've been trained to see them as separate, but there is an underlying pathology and physiology here. When you have insulin resistance and increasing over time, there's more adipose distribution, waist circumference showing up there. You'll see metabolic abnormalities with your glucose as it starts, as glycemic control of your glucose starts to no longer be in control over many years of high insulin in your body. Your blood pressure starts elevating. Your triglycerides start flying up while your HDL goes down. We see that pattern. So then the question is, okay, well, why? Like, what is insulin actually doing? And I think in med school, for anybody who's gone through med school or nurse practitioner school or PA school, we always remember, well, insulin's the key, right? Insulin's the key that opens all your cells so they can bring in the glucose. And then that's it. That's all we remember. It's like, yes, that's what it is. And that's all our medicines. That's what we do for all our medicines, right? So it's all about glucose entry into cells. And that is true. There's also the piece on the storage of all that energy in the liver. Once you have plenty of glucose going around, now you're storing, because our bodies are used to situations where we didn't have enough food in our environment. So we stored it in glycogen in our liver. That's how when we're sleeping overnight, we don't die, right? Because we have energy coming through our liver, kind of breaking down that glycogen into glucose for our body. We also do energy storage. When insulin is around at high levels, it's telling our body storage mode and fat production mode. The technical term is de novo lipogenesis. When we have high insulin as our background in our bodies, you cannot utilize your energy stores because your body is being told store the energy as fat. And it starts in the liver and then it goes to the rest of the body. And this is that rest of the body, the adipose, right? The fat cells start growing all over the body, and you have different distribution of where that shows up. How does that actually get to the rest of the body? That's that triglyceride. Those are those molecules that carry all of this extra energy in the form of fat throughout, and we can measure that. And then the last piece, my clicking is, sorry guys, little technical difficulties. Big slide, oops, kick me out. Give me 1 second. Can you guys see the big screen still? Okay, and then really just the metabolic slowdown. You're kind of you have plenty of energy, so you're slowing it down, not using it. So that's the kind of fundamentals of insulin. But then the question is, well, what happens to insulin when when we eat certain foods and the food is being broken up into its constituent macronutrients? So some of my foods that I eat maybe have a high carb intake, a high carbohydrate ratio. Well, we know that our insulin is designed to manage that bump, right? As the carbs come in, our insulin pops up to manage the sugar that comes from a high carb diet, depending on the type of carb. Not a lot of people know, but protein has a moderate response too. So even if you quote cut carbs and you do just pure protein actually elicits an insulin response. And then finally, fat actually doesn't, very minimal, if at all. So from a basic physiology perspective, whatever food that you're eating, which has a combination of these three macronutrients, is pushing your body to respond a certain way and to have an insulin response. And our body set point is all different. There's ethnic variation potentially, and this is all stuff that's kind of being looked at, individual variation. Questions on this so far? So, people have heard of the Atkins diet. Maybe it's high protein. Well, there is an insulin piece there, right? Even if you cut out a lot of the big spikers of the insulin. And I can't see the chat screen, so if there's chats coming in, please ask away. So then the question is, so what's the mechanism, right? This is me nerding out, okay? This is like, all right, how do we connect all of this? And so when we connect it to food, I'm gonna walk you through this. If we eat a lot of processed carbs, we're gonna talk about what that actually means, the pasta and the breads. That in our body, turns into a bunch of sugar, and our body says, okay, I gotta manage that glucose, so I get a lot of insulin going. If I'm persistently doing this all day, just eating bread all day or through years or whatnot, my insulin goes up, and then my body says, hey, there's a lot of insulin. I don't want to listen. I'm going to start being resistant to it. It's just too much. So I kind of go negative feedback, and I kind of turn off my receptors to listen, right? It's kind of like I often say, if someone's yelling at me and they keep on yelling, I start just kind of going mute. I just don't want to listen to it anymore. So then they yell more. Well, the body's kind of doing the same. It's like giving you insulin because all this sugar is coming in. And then your body's like, well, my muscles, I don't want to listen to that insulin coming. My pancreas, I don't want to listen to that. All of these parts, my brain, I don't want to listen to all that. Insulin resistance shows up in our different organ systems. It becomes a vicious cycle. And that actually it leads to and is connected through the metabolic syndrome, but fatty liver as well, which is not currently stated in some definitions of the metabolic syndrome, but others there are obesity and diabetes. What about other food and things in our environment? Artificial sweeteners and fructose, these both go straight to insulin resistance. They go straight to the liver. The fructose is not like your glucose. This is processed. Fructose is part of sugar. It's a part of the sugar molecule, is processed specifically in the liver and leads directly to insulin resistance. It doesn't actually cause a spike in the insulin. So these are two pathways. I'm gonna come to another slide that hopefully makes this more clinical. But let me pause with this to take some questions. Keto diets, yes, I think I didn't get that earlier, but the keto piece and let me go backwards since Dr. Jimena mentioned it. The keto piece is interesting because it's more fat, right? You're not eliciting an insulin response. It's minimizing the carbohydrate piece. It's having some moderate protein. And we'll have in session 3 or 4, we'll be going into some of those eating patterns. But any questions so far on just the mechanistic piece? Anything that's unclear? Okay. We'll be sending the slides to you all so you can review it. So how does this break down in terms of like the fructose piece? Because that often throws people. What, fructose? How does that work? If we look at table sugar, which is sucrose, it's really 2 molecules. It's a molecule of fructose and a molecule of glucose. The fructose gets only processed in the liver predominantly. At biochemical level, it's mainly in the liver. So whatever I eat of the sugar, it's going to my 3-pound liver. Now, if I am mainly consisting on white rice, it's mainly glucose. There's no fructose in there. Our body is designed to kind of manage glucose in all cells. So that goes to all 145 pounds, 148 pounds of me, whatever my weight is, right? All my cells are managing it. If I am eating 600 pounds, let's just make the math easy, 100 pounds of sugar a year, half of that 100 pounds, 50 pounds is going straight to my liver. My 3-pound liver. My 3-pound liver gets overwhelmed. Well, all this fructose coming in, it becomes fatty. The fatty liver gets overwhelmed and then starts distributing the fat elsewhere in the body. Now, if it's 100 pounds of glucose, my body can probably handle that short term, but over time, that eliciting of insulin spikes over time will create resistance, and then I may start developing some of these insulin resistance issues. What's unclear about this? Anything unclear about this? Okay. I'm going to keep on going then. This is some very interesting information. And I think many of you who have been managing diabetics, when you use insulin, you'll notice that you'll see that over time your patients gain weight. And this is just the idea of illustrating the insulin and insulin resistance cycle that actually leads to weight gain. There's an important study. There's an old study in 1998 over close to 4,000 patients. And they basically said, let's look at the weight. I mean, this is one of the findings that they found. What's the weight gain over years? And if we compared it between an intensive treatment, intensive meant either insulin arm, purely insulin, or sulfonylureas, the kind of oral medications that stimulate your pancreas to kick out more insulin. So essentially this insulin resistance cycle here happening exogenously because you're taking meds versus just a more conventional kind of eat a certain type of food piece. And they basically found over time, there was a differing amount of weight gain. And that was very powerful. This is a randomized trial as well. They were looking at different endpoints, but it was an important finding on the side. So we see this clinically. If you've been practicing long enough and you just see, I keep on giving my patients insulin, sometimes they got to use it, but you just also need to know there's a double-edged sword to it. And if I'm able to shift my patients off of the sulfonylureas, the things that can increase the insulin, and use the other drugs or the lifestyle, life habits piece, I may be able to minimize some of this insulin resistance. Questions on this so far? Okay. All right. So I know this came up during the case because I think we are so used to judgment and decision-making based on how the person looks. You know, and we often think biology is like phenotype, right? But size is not the whole story when it comes to metabolic health. And I think I say this because I think in medicine, I know in medicine, we can often shame people, fat shaming people who are heavier set. We have assumptions about that versus people who are thin set. Well, the evidence shows that a person that's more heavier set in this way, that there may be a higher percentage, 75% metabolically unhealthy, but there's 25% that are metabolically healthy. And there's a term that's used in medicine, MOH, medically obese patients who are actually, I'm sorry?
Obesity paradox.
There's that too. So there's this piece, right? It's not just about looking at that patient. And you can have someone who is, quote, thin appearing, who, yeah, maybe metabolically healthy 63%, but 37% metabolically unhealthy. And that's actually a bigger number when you look at the total number of people compared to here, just because there's more of these folks. So then the question is, okay, good to know. Where is all this fat?
So Stephen, can I just
going in?
add one
Yeah,
thing here?
please.
Because we are all really used to looking at body mass as a significant number when we're evaluating patients. And just to understand historically, that was a well-intentioned number that was originally sort of invented by someone at the CDC, basically to make the argument that there was this need for some kind of intervention for folks above a certain body mass, and that this was a public health crisis. But to understand that the number was just based on a bell curve, it had absolutely nothing to do with health outcomes at all. And as we all know, that someone can have a very high body mass, but a lot of that can in fact be muscle. So it's not necessarily a great indicator of health risk. It was quickly taken up after it was proposed by the CDC, by the pharmaceutical industry, because there was a very rapid recognition that this could be a great way to sell a lot more weight loss medication. So to understand a little bit of the sort of not so wonderful history of the BMI, and that we shouldn't really be depending on it so much as an indicator of health. We will talk a little bit more about waist circumference, especially within individual comparisons. So seeing if someone actually loses some of their waist circumference as they make interventions, that might be a much more sensitive indicator of metabolic health.
Thanks, Daphne. It was super helpful. And then I think the question is, we often think of fat as just fat. It's just on the surface, right? We really need to understand that fat, there's three types of fat storage. Fat is showing up in three areas. It's that subcutaneous fat that we see on the surface. There's the visceral fat around our organs internally, and then the fatty liver itself, in liver, as I was showing earlier. I want to share a few slides just to illustrate this from imaging studies. So this is to illustrate subcutaneous fat versus visceral fat. So you have two people. For those who don't know, CT scans is kind of like their feet is coming out to you, and then their head is going into the screen, and they're just kind of perpendicular to you. You have two people, same percentage body fat, same age, sex, and their BMI is 24, right? It's one indicator. This person on the left, their subcutaneous fat is this white stuff here. It's less than the subcutaneous fat. Actually, it's a similar total percentage, but you can see that there's a difference here. But the main issue is the visceral fat. The visceral fat here on this one on the right, you see all the white lighting up around all the organs compared to the minimal visceral fat here. So you have, when they measure it, 3.7 liters of visceral fat versus 1 liter of visceral fat. And visceral fat is associated with all of the insulin resistance downstream issues that we've already talked about, the glucose issues, the blood pressure issues, cardiac issues, even dementia and Alzheimer's type work. So that's just one visual piece. You got two people on the outside, phenotypically on the outside, they look the same, whatever, but now you look underneath and you see where the distribution of the fat is, and then you have a different perspective on who's metabolically more healthy and who's not. The next slide shows, and so there's actually, I should have said, there's a concept in the literature. It says thin on the outside, fat on the inside, right? And so I will say there's an ethnic piece here. In our South Asian community and other Asian communities, you may have thin on the outside, fat on the inside, where visceral adiposity in people that actually are slender is actually an increasing, is a major issue. And you wouldn't necessarily pick that up if you're just thinking the traditional kind of American sensibilities around obesity and weight. Mila, you said skinny fat. Tell me more about that. Or if you're willing to talk.
Oh, that's what you're talking about. That the acronym TOFI. TOFI.
Yeah, got it. Yeah, thin on the outside, fat on the inside, TOFI. So then this is just the fatty liver picture, right? Similar image now. You have your normal liver that looks this way, and then this liver's enlarged. It seems larger, but it's more dark. There's just a lot of fat happening there. This is the fat is that liver is overwhelmed by that 100 pounds of sugar coming in, and 50 pounds of that, going to the rest of the body, but 50 pounds of it concentrated there. So that liver gets overwhelmed and starts storing. Is there a way of finding, Dr. R is asking, is there a way of finding the extent of TOFI without getting a CT scan? That's a great question. I don't know if there are other associations and metrics. Daphne, do you know?
So there is, specifically in terms of fatty liver, there are some algorithms, but not necessarily in terms of,
the visceral fat itself.
Yeah.
I think that's a really great question.
The most sensitive thing, honestly, is exactly that kind of triad that we showed you that Mrs. C has of the increased waist circumference, low HDL, high triglycerides, high A1Cs, and slightly elevated BP. I mean, I think you guys are actually pretty good at it.
Right. Yeah. What those, and that's the part of thinking upstream.
Yeah.
So that's the fatty liver there.
Yeah.
So,
but the bottom line here is to not judge based on size alone, which unfortunately we've had a lot of bias there in medicine. Yeah.
Right. And so, who is then metabolically healthy? How many of you are metabolically healthy? What does that actually mean? Do you all have a sense of that? Quick question or quick reactions, either in the chat or what does it mean to be metabolically healthy? What would the parameters be?
I think a metabolically healthy individual has an A1C that's less than 5.7.
Mm-hmm.
Triglycerides may be less than 150.
Mm-hmm.
HDL above 40 for women, above 50 for men.
Yeah.
LDL, it depends on the risk factor or the age. Maybe for adults, that's healthy, less than 130. And
that's
then
a great
for
question.
those with diabetes and other conditions, less than 100 and other higher risk factors. And then let's say for BMI, for Asians, less than 23. And
Right.
non-Asians, less than 24.
Did you say less than 23 for Asians? Is that what you said?
And then for non-Asians, less than 24.
Great.
Or less than 24.9.
Yeah. So this is great. And is this Mila speaking?
Yes.
Thank you, Mila. I so appreciate you. You are definitely walking through the circle. So before I show the image, what you're doing is really looking at multiple factors to identify metabolic health. The numbers will shift, right? But it's not about necessarily a cutoff. Cutoffs are helpful, but if you're just slightly on one side of the marker and then the other, you're actually fairly close, right? And so they're helpful, but it doesn't mean, oh, it's a binary yes, no, now I am. But I want to share the numbers. When we look at the studies, less than 12% of American adults are metabolically healthy, meaning this definition was using more of the kind of metabolic syndrome piece, but waist circumference mainly as a proxy, glucose regulation, so the numbers you said as well, blood pressure, There's ATP3, for those who kind of follow literature, that was the higher number. If you use the 120/80, which is the more recent guidelines, it reduces this number down to 12%. So it depends on what cutoffs again. So the cutoffs are not as most important to me as really looking at your patient saying, are there things off that are not quite right? And where are they in their life? Triglycerides, certainly, and HDL, right? For women and men, 40 and 50. So these are the kind of traditional metrics. But we don't have LDL there per se. LDL is not as important in the same way as it was before. We can talk a lot about LDL. I'll just say one point about LDL and total cholesterol. It really depends what's happening metabolically in your body. If you're a diabetic, your LDL matters a lot more than if you're not. So we can go into a farther conversation on that. So yes, and yes, it should be above. That's an error on our slide here. So thank you very much, Dr. Chimena. I will go back and correct this before I send it out. The HDL should be above. Just following that. Let's see, there's some comments coming in. A person that his blood sugar, cholesterol, blood pressure, and ideal of any use of any medicine. Yeah, like if you don't need to rely on pharmaceuticals, that's one way. But there's people who you don't need quote medicines necessarily if you're at the 130, right, level necessarily. You might start with a bunch of other things. Thank you. So moving on then, this is great. Thank you, Myla. So this is the piece that I want to really share, this piece on working upstream in the exam room, because we've talked about upstream at the clinic. We've talked about social determinants of health, and Daphne was absolutely right to say, when I say risk factors as the cause, it's not just that. We know that people are sick because of their environments, because of other things beyond just diet. But since we're kind of doing a lot of the work on food, I wanted to situate that. What does this mean to work upstream in the exam room? This is where we as clinicians, we in healthcare have an opportunity to wake up, if you will, to use our muscles, to stand into and leverage our strengths in the exam room, not just say it's just left to public health to deal with. Public health has an incredible role to play with all of the things that traditional public health has done. In our country, public health and medical systems have been so disparate and not connected. We have an opportunity to close that gap and to use this mindset, this metabolic health approach, to looking at each patient that walks in the room, even if they're not complaining or they're not in the stage, you're not throwing a med at them. What are their metabolic vital sign parameters showing? So if we look at glucose over time and we look at insulin response as an earlier response over time, normally you might manage your pre-diabetic, your hyperinsulin patient, your pre-diabetic, and then they become diabetic. And you're like, what happened? Their sugar is going crazy. Well, if we actually looked 15 years before, 10 to 15 years before, we would have started noticing other issues. Insulin levels were rising. So hyperinsulinemia and conditions associated with that, that have that, PCOS, for patients who are dealing with women's health, obesity plus minus because of and overweight plus minus because of our caveats around size only, right? But there certainly can be a component there. You'll start seeing insulin resistance. You'll start maybe seeing early signs of elevated BP, not quite frank hypertension, but the numbers between 120 and 140. You'll see the pre-diabetes. The fatty liver is something we see in children now. It's one of the biggest causes of liver transplants now is fatty liver. Hypertension, you'll start seeing that. We often think of hypertension as only about salt. It's actually related to sugar too, because of these pathways. And then certainly frank diabetes. This is where I think most of us, certainly when I trained in family medicine, it's like, yeah, like pre-diabetes, you're lucky, you're good, you're okay. Just come back to me when you're sick, right? That's like kind of a lot of our mentalities. When you got the diabetes, I'll give you the meds. So we have the opportunity with this new mindset to start identifying and really aggressively going after our patients earlier on. Questions so far? Okay, we're at the hour mark. I'm going to go back to the case and I'll go back to Daphne.
So we're back with Mrs. C, and this is her second visit. She's come back to you after you've explained her labs to her, and she's had a little bit of time to think about it. And you've also put her other issues, her knee pain and her belly bloat, a little bit into context and given her some time to think about that. And I would also add, in terms of the belly bloat, folks had talked about diet as being a factor. A fatty liver in and of itself actually can create symptoms at a certain point. And this is something that actually I didn't realize till fairly recently, to be honest with you. So that is sort of another context to kind of give her as you're explaining her labs to her. And I don't know if you remember, her AST was a little bit elevated, and just given what we learned about where a lot of that fructose is going, you can all of a sudden envision Mrs. C's liver as kind of working overtime, right? And so that might be part of the belly bloat too. So Mrs. C comes back at visit number 2, and she says to you, can you recommend a diet for me? Let's go back to the classroom, Stephen, because I want to get your input on what you would start to tell her. What are some things in your real life work, whether you're working as a nutritionist or a social worker or a clinician of another sort, or physician or nurse practitioner, what would you say to Mrs. C?
Daphne, I would like to actually ask her, what do you eat, right? So usually, I don't think it would be good for me to just give her like a diet or talk about things without knowing the context of actually, you know, her culture and what does she eat. So usually what
so you would ask her, you would need to find out what Mrs. C eats and figure out what she would want.
Yeah.
Wow, what a radical notion that is. Thank you so much.
You know, usually I will ask the patient or Mrs. C, I will ask her, can you take me through a day? Like, what did you have for breakfast today? What did you have for dinner last night? What did you have for lunch yesterday? And then what were your snacks and your drinks? And then I will have like all the information of what actually does she eat. And,
wonderful, wonderful.
And then go from there.
So Allison is not taking the bait. She is not going to just start prescribing a diet for Mrs. C. She is going to actually turn this into a question. Other answers. I would like to ask, what is rich in their dietary habits? Yeah, exactly. So everybody seems to be agreeing with Allison here. Terrific. So, and you would actually start to break it down and figure out, it sounds like, literally by meal, what are some of the things that she is eating right now, and also what is she like, right? Because we know that one of the hardest things to change in our lives is what we eat. We are attached to certain foods and cultures and tastes and so on, and so unless we work within those parameters, it's not going to make a difference for our clients and patients. Okay, you guys didn't fall into that trap, boy. Okay, so let's move on, Stephen. So we left off at the exciting moment where Mrs. C asked you to recommend a diet for her, and you did not take the bait collectively. You really wanted to turn it back on Mrs. C and find out what she loves to eat and what she's eating right now. So what does Mrs. C tell us? Our next slide, is that? Oh,
right there. I'm just gonna do a framework slide.
All right, you know what? In terms of, maybe we'll go back to that, Stephen, because now I'm seeing in terms of, I think the next one is Mrs. C's. Let's go. Oh no, did we we move her?
Yeah, we moved it slightly below. So yeah.
What?
We moved it slightly. I moved it slightly below, so it'll work. This will work. Yeah.
It's like when you come into a room and you can't find the furniture anymore. Right, okay. Right. You know what would be really great is, all right, let's go ahead and go with the sequence it is right now. So as we're talking about how we might want to work with Mrs. C, there are actually 3 pathways that we can be taking. We can be figuring out what Mrs. C eats and work with her on that. We can figure out sort of when she's eating, and there's actually interventions that can be done along that pathway. and how she is eating. And there's actually some interesting research on how, that also can be an effective approach. Today, what we are going to do is start working on what Mrs. C is eating, and exactly what you all have mentioned is sort of figuring out what she's doing now and seeing how we might help her change that. And specifically, we are actually going to focus on drinks. And the rationale behind that is that if we look at the greatest sources of added sugar in the US diet, and we have just spent the first hour today learning how sugar sort of drives this insulin resistance and leads to this cascade of symptoms from hyperinsulinemia to prediabetes to frank full-blown diabetes and complications. One of the dietary bad boys in this really is what we're drinking. And if you look at the greatest sources of added sugar, 2 of the top 3 in terms of teaspoons of sugar per day are soda, energy drinks, and fruit drinks. So that is actually today where we have decided that we want to start with Mrs. C in order to make the biggest difference. Next slide. So, there was supposed to be a blank question mark there. Can you get rid of that slide for a second?
Let me just shift that.
Sure, what happened there?
No,
Sorry,
this is
two of us creating these. So just to go back to the classroom here, if you wanted to figure out specifically what Mrs. C is drinking, that might fall into that category of those top couple bad boys, what would you ask her? What are some of the words that you might use?
Maybe asking, when you're going through your day, how do you refresh yourself?
That's a really great way of in terms of drinking. Okay, I like that. Other thoughts? Oh, we're back at the.
Sorry, I don't know why.
Asking to describe her in the day, like yesterday, what did she drink?
Mm-hmm. Okay, great. So what did she drink? Okay. Great. So next slide now. I have found that oftentimes when I just ask patients what they're drinking, they kind of forget a lot of what goes in. So I have actually found that it is sometimes helpful to, be very specific and say, this includes sweet tea, energy drinks, juice, Gatorade. It's amazing how many times patients are surprised when they sort of leave juice off the list, for example, because they think of that as more this super healthy thing that they don't even need to mention. So I tend to go through the list: cocktails, beer, and wine, just for them to understand what is the full spectrum. And actually another one that needs to be added now are the vitamin waters that is not on this list, because those are another place where I think that folks don't even necessarily think of that as being something that would be a sugary drink. So I think that you're all going to find your ways of talking about this with your patients, but recommendation is to really start to specifically list the drinks. So next slide. Why do we care about sweet drinks? Well, we already talked about the insulin resistance and blood sugar, but also, it is this source of calories, which actually has really no other benefit in general. I mean, the juices have a little bit of the vitamins, but actually most of the vitamin is left behind in the pulp, which is the part that people don't drink. And in general, what it is stuff that we call empty calories. It also turns out that when we sort of drink our nutrients, that it doesn't actually have the same effect on satiety, on feeling full, as when we're actually eating solid foods. And there might be a lot of mechanisms for that, including the fiber piece and so on. That has a lot of additives, a lot of caffeine, and can act as a stimulant. And as we learned earlier, there's other pathways to insulin resistance, and there's some growing evidence that the alcohols and the sugar-free drinks, the artificial sweeteners, might also contribute to fatty liver. So this is why we kind of start with the drinks as this low-hanging fruit where we can really make a difference with our patients. Next slide. Stephen, I'm going to let you take it from here.
Sure, this double gulp, right? This is like the huge things at 7-Eleven. You'll see all the sugar stacks. I think I counted as like 44 of these little stacks, and each of those stacks is essentially 1 teaspoon. So 44 teaspoons. I think the question is, I think it's important for us, and something we don't always remember in our metrics of what we learned in medical school or nurse practitioner school or whatnot is, well, then how do we actually think about sugar? So just 2 key numbers when you think about it that has clinical application. So 1 teaspoon of sugar is 4.2 grams of sugar. So a teaspoon is 4.2, and I just rounded down. A teaspoon is 4, simple as that. So that last big gulp or double gulp had 44 of these sugar cubes or teaspoons. That's a lot of sugar in that 1 drink. What's the recommended maximum added sugar per day? There's some kind of gender, if you will, and age kind of distinctions here. For men, we often say less than 9 teaspoons. So when I talk to my patients, I toggle between teaspoons and the grams, and I'll share with you more why. But the teaspoons is a nice visual. That's a lot in a whole day, 9 teaspoons. For women, we say less than 6 teaspoons, so 9 and 6 or 25. I'll do a grams later. I'm going to go through the teaspoons. And then for children, none before age 2. And then maybe 3 to 6 teaspoons total depending on age. Now, the teaspoons work well for patients when they're first hearing about it. When they're actually, when we give them an opportunity to kind of start being a sleuth and an investigator into what they're actually eating and doing nutrition labels and stuff, that's where the numbers, the grams make sense, because everything's labeled now. So what I often say for men is, okay, what's my magic number for how much total added sugar when I'm working with my patients? I say, men, remember when you turn 40? Just think around 40, that's 38 grams, or 40 is when is the max. And this is just general recommendations. If I have a diabetic, I might go down on that, right? Depending on how aggressive they want to be and how much they want to work on this. For women, I might say you're forever 25, right? So just remember you're forever 25, and you got your 25 grams of what you want. And when we get into fiber, the numbers are very similar. So this is why I kind of use these ways to remember. And I talk about it this way with my patients, so they remember. So here's some examples then, and like what would that actually look like? Just the visual. If we followed that to the T and said over a year, what would that look like? For men, that's 3 of these 10-pound bags. So each of these are 10 pounds of sugar. It's 30 pounds of sugar in a year. And for women, if we followed that recommendation, 25 grams, et cetera, that would be the 2 there. And for children, down to 1 after age 2. Well, what are we actually consuming? Do you have a sense of what the American public is actually consuming? Give me a number. How many of these bags, or how many total pounds of sugar per year? 10 pounds. 10 bags. Oh, 10 bags.
Sure, it's more than that. I mean, 10 times, I would say, for kids. For men and women, maybe 3 times.
Yeah, so the actual 8 to 10 bags, yeah, we're getting pretty close. So in the actual year, the average American is 74.4 pounds. So 7.5 of these bags, of these 10-pound bags. So remember, that's a lot of sugar going to your liver. That 3-pound liver is having to work overtime and is going to become fatty. And then it's the triglycerides are going to pop up. And you're going to start getting fat distribution viscerally, maybe if you're predisposed that way, or subcutaneously. So then the question is, okay, great. So then what about juice, right? We're focusing on just juice. My patients say, oh, I don't drink juice. I don't drink soda, but I drink juice. And I say, okay, well, how much sugar is in this juice? Added sugar, 34 grams. What's the magic number if you're a man? In a whole day, 38, 40, right? If you're a woman, forever 25. Yeah. And I say, and so I might have that conversation in grams where I just say, you know what? That's 8 teaspoons of sugar in that 100% orange juice that you got.
Yeah, just to clarify, Stephen, that is not added sugar per se, but it is sugar. So, yeah.
Yeah, this label doesn't show added sugar.
Yeah, it doesn't. That's a new rule. This is actually an old label, I realize, but it's a new rule that we actually do have to show added sugar.
That's right. So, yeah. So the new labels will have added sugar because of the legislation that's happened. So I say, well, how does that compare against Coke? Right. This is 12 ounces of this orange juice and 12 ounces of Coke. The added sugar is an updated label, 39 grams. That's around 9 divided by 4, roughly 9 teaspoons. So when I say that to my patients, I start with the teaspoons. They're like, whoa, really? It's about the same? That's a lot. I drink 3 of these a day. I'm like, yeah. And what's your magic number? That's when I start getting the grams, right? So I make that conversion. So there's a nice, simple way of just kind of translating this to the 15-minute visit to the exam room. So how do you talk about it? When you're in clinic, what's your preferred approach?
Stephen, I actually had a conversation like this with one of my patients before, because they were asking, they were a sweet tooth, so everything had to have sugar. So one of the things that I asked them was, when you take your, like, because they were really big on tea, but they had like loaded it with sugar. So I was like, are you using the tea for refreshing yourself, or because you were thirsty, or was it just a habit of some sort? So her response was more like, she wanted to be refreshed. So she liked it nice and cold with a lot of sugar. So I said, how have you tried removing maybe 1 teaspoon out of that? And then it's like a slow gradient, I guess, to lessening. Maybe, start with, see if you notice a difference. And then, kind of challenging them to lessen that with the same tea that she likes, but maybe less. Because I said, your tongue is going to eventually not pick up as much of the difference if you do it gradually, and then eventually you're not going to be using as much, and it's still the same refreshing tea that you've been using. So sometimes I tend to do it that way, so it's not as shocking, and the patient actually realizes, oh yeah, it's not a big difference from what I'm used to.
It's super helpful, Dr. Jimena. You are taking kind of a patient-centered approach and moving them down the gradient step by step in ways that are successful for them. There's a Stanford professor that has done a lot of work on what he calls tiny habits. And I often use this tiny habit approach with my patients. It's really about building that tiny habit. And the example I will use is like a patient of mine that doesn't want to floss. They say, can you floss 1 tooth? That's the tiny habit we're going to try, and anchor that to your brushing. They do it. And then they're like, oh yeah, I can do more, right? So something like that. Other ways that other folks talk about this.
There's a question in the chat, Stephen. What explanation do you give patients who state that they have 0 sugar vitamin or Gatorade drinks? Is it truly still improvement from their regular versions? And then there were also 2 suggestions, trying fruit infused waters or lemon waters.
Fantastic.
Question and a comment.
Great. So the first one, and I'd love to hear how Daphne thinks about it too. I often look, well, if there's great, added sugar is 1 step, right? It's a simple, easy way. And then others in the marketing companies know, oh, some people are not tuning into added sugars. So what about using the sweeteners, right? The artificial sweeteners or natural sweeteners. That's what I would say for part of it is often these have, if you start looking at the ingredients, have other pieces in there to make it actually sweet. And that has there's lots of different type of sweeteners, but they have the preponderance of evidence is moving towards insulin resistance as a direct pathway. Daphne, do you have anything else you want to say on that?
Yeah, I agree. I mean, there's two issues. One is that there is increasing evidence that a lot of the artificial sweeteners actually have a metabolic effect directly. But there was also something that was just mentioned, which I think is a really great point, is our taste buds. And a lot of the artificial sweeteners sort of hit our taste buds and hit our receptors in our brain as sugar and give us this standard for sweetness that then we are always trying to emulate, and our food does not taste right unless it's that sweet. And so a lot of the work I do is getting my patients to kind of dial back, exactly as what was just mentioned, the amount of sweetness, so we can start to taste a lot of the more subtle tastes in our diet, the things that are a little bit more acidic and a little bit more sour and a little bit more umami and so on. But that requires actually dialing back the sugar. So I give both those arguments to patients that, you know, the artificial sweeteners are probably not great for our health directly, but they're also just making us more addicted to that sugar taste in general.
Absolutely.
But wonderful questions about infused waters, lemon waters, carbonated mix. Let's go on to our next slide, because I think we answered that.
Yes. And that's this remove and replace piece. So it's about striking the balance, right? You can remove and yet you put in the replace with this lemon infuse or the fruit infusions, which is a great way to do it. And I think it's really important because we often are into taking away, and nobody likes that, likes things taken away. It's a very basic, fundamental human economics piece. They would rather you add. And so if we're going to move towards removing, which is an easy thing for us to do, we want to have the alternatives. And Ronald's already given us a number of them: the carbonation, the lemon waters, the food infusions. The other examples for, like Dr. Jimenez was saying, well, what about your removing of the sugar piece to the coffee or the tea, or switching over to the teas, right? There are ways to do it. I spent a lot of time with one of my patients recently just on that. They're just so used to having the sugars in there. They're like, I have to have it. And so we just started finding alternatives, cinnamon. And it was lovely. And where she was able to kind of gradually come off of the sugar and actually started tasting things, to what Daphne was saying. Other drink ideas, we have the teas, right? We have the water. And so just an interesting point on water. How much water do you actually need? And then as you think about that question, I think it's important that we feed our hunger sometimes with the water first, because it's actually the thirst that's telling us, but we mistake it as hunger, because we can get fluids through food. Often people say 8 glasses. There's kind of, I've used different calculations in my past talks, kind of looking at the literature more deeply. 2004 was one of the bigger recommendations. This is fluids per day, right? This is from the National Academies of Science, Engineering, and Medicine. 2004, they were recommending total fluids a day, not only drink cups of water, but fluids per day, 15.5 cups for men, 11.5 cups for women. This is probably assuming 70 kilogram men and different size for women. They are clear to say though that this covers the fluids not only from the water, but other beverages and food, because food itself, depending on what foods, some of it's 20% of it is daily fluid, is just from the food itself. So if you just took that rule, 20% of this, that's around 3 cups. So you'd be down to about 12 in color, right? That's just one simple way. But hydration is a fairly important piece, and it's helpful for us when we talk about hunger and other pieces. I'm going to keep on moving and back to the case and give it back to Daphne.
So Mrs. C again, this is after you so astutely refused to give her a diet and asked her what she ate, and decided that the first thing that you were going to do was work with her on what she was drinking. But then you actually find out the food she's eating as well. And your focus is actually on her carbohydrate-rich foods, and we're going to get into why in a second. But you're asking her specifically about those, and I'm curious to hear how you ask it. Is that going to be the next question there, Stephen? Okay. Oh no, it isn't. Okay, go back for a second. The slides just shifted around a little bit, but let me find out from you. How would you ask this question before we get into what Mrs. C answers? How would you ask her about her carbohydrate-rich foods? What are some questions you might use?
Can you hear me?
Yeah, once you go into the classroom, Stephen.
This is Adrian. Can you hear me?
Yeah.
Oh, hi, sorry.
Hi.
I'm on my colleague's computer.
Oh, now we can't hear you. Now we
Oh,
can't
there we
hear
go.
you.
Sorry. I think I'm on now. Yes. Okay. I was just mentioning. I think it's kind of fun when the tortilla topic comes up because I tend to ask them, you know, about how many tortillas do you have in the morning, lunch, etc. And then I tell them, okay, let's add them up. And when they add them up and they say to themselves, oh wow, a dozen or more, it kind of makes their eyes open a little bit and bring a reality of what's been consumed throughout the whole day. And that's how we tend to continue on with the conversation about.
Adrian, we cannot hear you. Is it through Erica?
I think Adrian was done.
And Daphne, are you speaking? We can't hear you if you are. Adrian, if
No,
Adrian's
I was just saying that is wonderful. And you asked specifically about foods that you think might be within the dietary preference of that patient, either culturally or because they stated that. And Mrs. C is from Veracruz originally and loves tortillas. So asking specifically about tortillas.
Erica, were you about to say something?
Giving them alternatives on what they can swap things out with rather than like saying you need to cut out bread completely, just giving them options and other alternatives because they get really discouraged when you say you have to stop eating all these things. But when you give recommendations too, it makes it a little easier for them to comply.
Remove and replace, right?
So we're going to get there in 1 second, but just in terms of the question that you're asking to even figure out what kind of carbohydrates they're eating, that can sometimes be challenging to get at because as we're going to talk about in a second, that word carbohydrate means different things to different people. And it really is just carbohydrates are just nutrients. They exist in a lot of different foods. So a lot of times the way I describe it to patients is what kinds of breads, tortillas, starchy foods, rice, I'll go through the list again, just as I explained with the drinks, so that they understand what I'm trying to get at there. Then what Mrs. C answered, let's get to her answers.
Let me do this one piece just to illustrate what you were saying, Daphne. Daphne goes straight to not the carbohydrate as the nutrient, but like the different types of carbohydrates, right? So we have our leafy veggies, legumes, our nuts. Well, how do you actually say legumes to your patients? Right? You want to get familiar with you're going to talk about beans or peas or lentils? Like what works for your South Asian patient? What works with your Latinx patient? What are the familiar foods that you know of that you're a go-to when you start talking about this with patients? Just like when you talk about metformin, or you're talking about glipizide, or you're talking about insulin, or some of the newer agents, SLD2 blockers and all of that stuff, transporters and stuff, right? You get refined in the same way. Fruits as a carbohydrate, the kind of starchy veggies, what are your go-to ones? The grains and breads, and this is where Daphne's going into the baked sweets. These are carbs too. And then this is where we're landing now on, is this piece around, well, what does it look like for number 2? Once you got the sugary foods out of the way, what's number 2 for something you could try on?
Yeah, I would actually put starchy veggies in that box too. But the reason that we're talking specifically about grains, breads, and baked sweets is more from an epidemiologic perspective. That when you actually look at where the greatest sources of added sugar are in the US diet, remember we figured out that fruit drinks and soda were there definitely at the top of the list. But look at what's number two. Number two is grain-based desserts. And then if you go down to sort of within the top 10, number 9 is yeast breads. And so these are places, and then quick breads are shortly after that. So these are places where we can quickly start to make a difference in added sugars if you look at sort of the average American diet. So those are why we've sort of chosen number 1 and number 2 as drinks and then these starchy foods, right? So this was the way that I tend to ask the question. In a typical day, how often do you eat baked desserts such as cakes and cookies? And how often do you eat bread, rice, pasta, or tortillas? You know, depending on the culture, I might also ask about potatoes as well. So let's go on, Stephen. So let's talk a little bit more about processed foods and why it is that these are ones that are of specific concern in terms of health. I'll give this to you, Stephen.
Great. So processing of food, right? You have minimally, there's technical ways, it's called the NOVA classification, but we don't have to get too technical about that. And I've kind of simplified it here to say, well, we have our unprocessed or minimally processed, right? Something like this. This corn is that. Then you have some where it's processed, right? And you kind of break it down into something that you can use as a culinary ingredient like masa. And then you have much more processed or ultra processed. It's heated, it's treated with chemicals to get you this caro, this corn syrup, right? So it's kind of varying levels. This is the most close to nature. And then we use these elements in our cooking practices. And we're definitely using a lot of this now, right? Especially in a lot of the processed foods. Well, what does this mean, right, in terms of the process of food processing? So if we have a whole food, you remove the fat, the nutrients and the fiber, because you can't have it on the shelf when you have all these things, right? The fat goes rancid, so the food doesn't last as long. If it doesn't have a lot, if you freeze it, then the fiber gets messed up. So you take all of these things out. Well, if you take all of these pieces out, that has less taste and texture now. So who would want to buy this food? Well, in order for people then to buy this food, then you have to add in a bunch of the other stuff, right? This is when you look at the ingredients, you add in the sugar, the salt, the coloring, the emulsifiers, because they can't all stay together, the preservatives, trans fats, and that's being legislated out. A bunch of the seed oils in all our baked goods, the omegas, omega-6s in particular. Now it looks good, tastes good, it can hang out on the shelf for years, right? And that's your processed food, your purple food. So that's a simple way of just kind of knowing the processing behind it. Then let's take an example in grains. Let's first start with its closest to nature. What is a whole grain? How would you answer that?
A whole grain is a grain that has the 3 parts still intact.
Mm-hmm. So the 3 parts, what are the 3 parts?
The bran, the endosperm, and the germ.
Wow. You know, I think Mila hit it exactly on the head, right? So all 3 parts, the bran where there's all the insoluble fiber and minerals, the germ where you get this fats and vitamins, and then the starch piece in the endosperm. And when it's, we'll talk about what happens to this when you're processing it. So what are examples of grains from your culture? Whichever of you want to talk about the grains that you eat. Like I grew up eating rice. I didn't know it was a grain. I didn't think about it as a grain when I was a kid. It's just rice. So what are you all eating? All right. Rice also, thanks Marjorie. Baos.
Mm-hmm. Yeah.
Beans, I'm sorry, say that again.
Yeah, I was saying beans or lentils.
So that's more on the legume side, but for sure, I mean, in general, when we think about it, it's like, yeah, it's a whole food there. Oats, for those who like oats, the barley, the whole farro for folks who have that included in their diet. Brown rice, not the white rice, because the white rice is no longer whole. Even wild rice, not technically rice, more of a grass. So this is just the beginning of kind of thinking, well, how do we actually identify a whole grain? So then let's think about, let's kind of demystify what actually happens to grains and how to actually process, how it gets processed. Save your whole grain, the 3 parts that Milo was talking about. You have your whole grains like wheat kernels and oats, right? You mill it. That's the processing piece. You mill this down into wheat flour. And that's either whole wheat flour or enriched white flour, right? In a lot of your breads, but it's still processed. It's still pulverized down. And then you get your flour that you use to make your pastas and your bread, or you get your oatmeals. And your oatmeals could be varying levels of processing, from kind of steel cut all the way to instant. You have your whole barley or your whole farro. That process of processing is called pearling. You process that, you pearl it, and now you remove all of this extra stuff, and now you have your processed barley and your farro. And you'll see here, pearled barley. It is not a whole grain. Brown rice. For rice, we polish our rice. And when you polish brown rice, you remove all of this around the bran and everything, and you leave everything, you leave the endosperm, you have your white rice. So in general, if we're gonna go straight to the whole, those are the greens. You can have whole oats, whole farro, wild rice. You might not necessarily eat the wheat kernels, you might do wheat berries separately. Questions about processing and just kind of understanding the sourcing of where the products on the shelves and then the steps it takes to go from the original whole piece. Okay, so then we go into, why are we limiting the processed grains? And so let's just take 2 examples. You might have whole oats, but they're actually processed now. They're processed so that they're now cut, and then now they're rolled, and then they're ground. Is there a difference? Or you might have your wheat, and then you start processing it along the way, and now you get the white enriched bread. We want to limit the processing, because the processing over time, depending on which processing step you use, eventually leads to this food being easily broken down. And these digestible carbohydrates, if you will, that nutrient broken down, that raises the blood sugar. There's not as much fiber when you process it, often because it's taken out, and then there's fewer nutrients because of what we were saying, the removal of certain sections. And then there's more additives. So whole grain is great, but then you also want to know how much of that whole grain, how processed was that whole grain?
And I want to add here that this is tricky and confusing, even for folks who really have spent a lot of time, working with food and nutrition. For example, I grew up eating couscous, which I always thought was this, I didn't know it came from a couscous plant. I thought it was this whole grain, because it has this feeling of a whole grain. But, as we all know, couscous is processed wheat, right? Into small balls. And even with oats, there's rolled oats that can take you 20 minutes to cook, but then there's also instant rolled oats, which are actually pre-puffed and sometimes even, have a pre-cooked aspect to them. And those have very different levels of sugar. So this is, relatively complicated stuff. And I think what is important as the take-home message here, because we're not expecting you guys to become experts in grain processing, is just that the more processed that a grain becomes in general, the more easily digestible its carbohydrates are, and the more it raises sugar. And there's actually lots of caveats there too, because pasta, for example, you think of as a relatively processed grain, but it turns out that pasta, especially if it's cooked al dente, actually doesn't have that much, carbohydrate to release. But in general, this is a helpful tool in terms of how to think about things.
I think in how I kind of summarize it in my head is it whole or not? And then even if it is whole, how processed is it? And so that was part of the point here. Just to kind of remind folks, just the mechanisms again, the processed carbs create a high insulin state background, then your body gets into resistance, it becomes a vicious cycle, and then you get your multiple endpoints. So just to remember that. How to avoid processed foods. What's a simple way that you could teach your patients, if you will? This is number 2, you're working with Miss C. You say, okay, well, how do we actually actualize this in clinic in 9 minutes at 1 o'clock, right? So what do you say? Do you have any language around this? How do you tell your patient about avoiding processed foods or processed carbs?
I'll use what you said a while ago, Steve, that to choose foods that are close to nature.
Mm-hmm. So you try that on with your patient and they're like, okay, what does that mean? I'm not out in nature, but yes, absolutely. Or maybe I am, I get it. You know, that tomato is close to nature. It's different than the pizza or the tomato or the ketchup, right? So yeah, one simple way is to potentially say, avoid packaged foods with the mystery ingredients. So package, anything in a package doesn't totally work out, right? Because you can have almonds in a package that have no salt and everything and you're okay. But a simple way is if it's packaged and it has shelf life. And so they've taken a lot of the fats and the fiber out and they're putting in a lot of the junk. If you can't pronounce the ingredients, and that's one simple way. And then shop the periphery of the market, although some markets are already getting astute to that. But anything in the aisles tends to be shelf stable processed stuff. So you start removing some of this, you got to add in and replace. And so
we just, someone just recommended reading food labels. Okay, perfect.
So I'm going to do, you know how in med school, for those who went to med school, we looked at x-rays and we had like 1, 2, 3, this is how you're supposed to look at an x-ray. We're going to do that with food labels. And I'm going to walk this through and we're going to do some participation. I'll see if we can do this in 7 minutes. If not, we'll carry it on to the next time because you guys have been super interactive. So this is just us getting to know you. So this is your nutrition facts, right? My gosh, you're going to tell this to your patient? There's so much. I don't even know what this means, right? How do I make sense of this? So here's the kind of the x-ray equivalent. Look at your serving size first. Number 1. What's the serving size? There's 20 servings, but the serving size is a packet. Number 2, what do I look at? Servings per container. How many servings are there? Because sometimes they give you a whole bunch of stuff. Sometimes it's a little and you're like, whoa, there's a lot I'm taking in. Number 3, fiber content. Just jump to fiber. How much fiber? We haven't gotten into fiber. We're going to talk about it later, but that's one key piece. Number 4, this is the stuff that we led with, the added sugar. Don't look at the percentages, just what's the total added sugar? Let's start there. When we get our diabetics, we can talk about carbs and net carbs and all of that other stuff. But for now, let's just go basics. 1, 2, 3, 4, added sugar. Pay attention because I'm going to be asking you guys to do a few examples. And then ingredient list. How many things are on the ingredient? Is it mystery ingredients or is it pretty simple, straightforward stuff, less than 5?
Even someone just wrote, if it's a preservative chemical if you can't pronounce it, it's a preservative chemical additive. I love that suggestion. That's actually often what I tell patients. I say, there's something you can't pronounce, just put it back on the shelf, you know?
Right,
or can't even fully, the word is so long, you can't possibly even read it or recognize it. Yeah, terrific
Absolutely.
suggestion.
Thank you, Ronald. So we have our 5 steps: serving size, serving per container, fiber content, added sugar, ingredient list. Let's look at this one right here. This bread, it's sprouted grain bread, Ezekiel bread. What's the first thing you look for? Serving size. Second thing, how many of these serving sizes are in this whole thing? Because did I eat the whole thing in one thing, in one fell swoop? That's the serving container. I kind of flipped that one around. The third one is the dietary fiber. And then What's after fiber? Added sugars. So we got 0 added sugars. We got some good fiber there. And then the last one, can you pronounce most of this? Now, obviously there's health literacy issues and all of that, so we're not saying that, but in general, there's a bunch of organic, there's wheat, water, and whatnot. That's the ingredient list. All right, I'm gonna ask for, so that's more healthy. I'm gonna ask for I just walked you guys, I showed you one. So now someone do the next one.
Stephen, can I
Yes,
interrupt for a second?
please.
I also, one of the things that I say to patients is really with step number 1, look at serving size. If you're not happy with that serving size, if you're like, that's ridiculous, I would normally want to eat 5 of that to be happy, and they're saying 1 is a serving size, that's usually an indication that they're trying to trick you with this food and put it back on the shelf just for that reason. So step number 1, if you're not happy with that serving size, maybe it's not the right food for you.
You got it. So I need a volunteer here. We're gonna break down Pepperidge Farm in your Safeway or Lucky's bread. It looks great, right? Light, 7 grain. Here's the nutrition facts. Who's the first volunteer? Or type it in. You know, I actually am being reminded, I do need to, because of CME, I need to pause and give you a chance to the survey. So we're gonna pause on this and take it up from next time. You guys are so interactive. You got your 5 steps. I'm gonna step out of this.
And I need to get off right at 1 because I have to go actually start seeing patients. But I really look forward to our next session.